Hello everyone, I'm Asadur Rahman from Purdue University. I'll be presenting our work SARTRES, a semi-autonomous robot teleoperation environment for surgery, and some of recent works that we are doing in this project. Access to austere environments is challenging for medical and trauma personnel. A robot on standby can provide real-time and effective assistance within the golden hour. Teleoperation has a great potential where modern surgery is not feasible, especially in many austere settings. However, there are challenges in the teleoperation. This process requires to send a very large and continuous data stream such as robotic kinematic, high definition video, etc., which often requires high bandwidth. In addition, surgery is often a continuous process, and any interruption can cause severe damage to the patient. We aim to tackle these issues by sending high-level commands, which is small in size, instead of a huge data stream. And for the delay, we allow the robot to perform for a short time procedure autonomously when safely possible. Here is the overview of SARTRES framework. The operator works with a simulation that corresponds to the remote robot's environment. A recognition module recognized high-level surgical actions from the trajectories and video seen. The recognized high-level surgical actions are sent to the remote robot through a communication network. The remote robot relies on high-level instruction for its execution. Maneuvers are learned from control environments and then transferred to new settings. We experimented on the desk dataset for peg transfer task, which is used to train laparoscopic skills. We used three robotic platforms from desk: Taurus, simulated Taurus, and Yummy robot. 7 surgeme steps were defined for completing one peg transfer. For each platform, it has video and kinematics data with annotated surgemes. Now I am going to talk about recognition and execution module in details. Recognition module. Our approach combines features extracted from video frames and kinematic data to perform surgeon classification based on the multimodal recognition. The resized image is passed to a ResNet to extract image features, and then a PCA model is used to reduce the dimension of the features to a lower dimension. Additionally, we extracted features from the kinematic data by encoding the features into a shared representation. The searching instances were resampled to a fixed number of frames to generate sequential features instances for each surgeme using linear interpolation. The visual and kinematic features were used to train two separate supervised learning algorithms. One classifier is trained using visual features and other classifier is trained on the kinematic features. The final class probability is calculated as a combination of the probabilities given by the classifiers using kinematic and video features. As of the execution module, it has two components, a visual recognition unit and a surgeme execution unit. The visual unit performs scene recognition to extract features or parameters relevant to the surgemes, such as object pose and point of interest. Leveraging this information, the execution unit employs a model-based approach to perform the surgemes sent by the recognition module. The execution module receives high-level surgemes commands, which include the level of the surgeme to be performed and the relevant parameters such as peg number or dominant arm, etc. Here are the steps for a surgeme approach. It first identifies the target triangle by matching its position with the tracked poles, and then it identifies the closest corner of the active gripper and approaches the triangle. For surgeme align and grasp, the system identifies and selects the mask corresponding to the triangle of interest. This is used to identify point of interest. The system then calculates the grasp point and performs the grasp. Details of the rest of the surgemes can be found in our paper. We evaluated our framework with 75 peg transfer trials, 25 for each robot from desk dataset. These trials work as the operator side information which are recognized and then sent to the remote side for execution. We used Yummy Robot as the remote robot for this experiment. We measured the performance on per surgeme and per complete transfer, and we evaluated the autonomous capacity of the system using mutual information-based degree of autonomy. SARTRES achieved an average accuracy of 91% for surgeme recognition and a success rate of 86% during surgeme execution using a model-based approach. The overall task accuracy is 53% and the framework achieves a 99% degree of autonomy which we defined in terms of mutual information. Now, I am going to discuss some of the recent progress of our project. We observed that in SARTRES, the combined task performance is not as good as the individual recognition and execution module. A key reason is the absence of feedback. If one of the seven surgeons failed, the whole task is considered as a failure. Thus, if the robot can recover from a failure, then the overall performance would be better. We are currently working on to address these challenges. In this scenario, the recognized surgeon sent to the remote robot continuously, and an LSTM-based recognition module predict a surgeon leveraging the history of the activity data. In the execution module, it receives this prediction confidence and decide when to start executing with a confidence threshold. Note that with a high confidence prediction of surgeon and parameters, the remote robot might start executing before the operator finishes its surgeon at hand. The activity information is sent to the operator side and displayed within the simulator using alpha blending. Minimal information, that is, the objects and gripper coordinates, are sent to the operator side, and the alpha blended movement, which is shown in the yellow color, is reconstructed in the simulator. In case of any failure or incorrect execution in the remote robot, the operator might decide to correct them, thus perform the surgery again. Here is a demonstration of the full loop framework. The operator starts a surgery, and with a good prediction, the remote robot performs the approach surgery and wait for the next command, which is align and grasp. In this case, the robot finishes the surgery before the operator because of accurate surgery and parameter prediction. When operator finishes approach and start align and grasp, the recognition module predicts that surgery and parameters. It starts executing align and grasp. And the same for the leaf triangle. We thank our sponsors for their support in this work. Thank you for your attention. If you have any questions or comments, feel free to reach out to us.